unlike the knee where usually there's an injury, like there's a point in time where you have an injury and that's what triggers that beginning of the OA process with an ACL tear or meniscal tear. In the hip, it tends to be more related to the shape of the joint and things that might have been there for a while. And so particularly FAI syndrome, where you might have cam morphology, that bump of bone, or hip dysplasia, where you have a shallow socket, those two shapes of the hip can predispose you to a higher risk of developing hip osteoarthritis. But what we need to remember is even though the relative risk is high, so for example, having cam morphology by itself, the bump of bone, makes you 10 times more likely to develop OA. And if you have that with reduced range and pain, then you're around about 40 times more likely to develop hip OA. Even though the relative risk is high, it's still only a small number of people with those things that go on to develop OA. So it's not everybody with those things that gets OA, but it certainly can put you at risk of developing hip OA. But it can start early, and ideally it would be nice in the hip if we could capture those people really early and prevent that from developing, because I'm sure Nigel would, wearing his surgeon hat, would know that for hip OA in particular, there seems to be a tipping point where people will grumble along and then they fall off the cliff. And when that happens, it's much harder to be able to do anything other than the definitive treatment, which is hip replacement, which I know we're going to talk about later on. So maybe I'll hand over to Nigel now.
Yeah, basically answered everything for me. That's the problem of going last. But just to expand a little bit on what you both have said, osteoarthritis as a definition has definitely changed over the last couple of decades. There's always traditionally been taught and told that it's wear and tear of the articular cartilage or the joint surface. But interestingly, over the past 5 to 10 years, particularly in my sphere, there has been a lot of work trying to establish the metabolic role that our body plays in arthritis development. And there's this very interesting study out of America just after COVID looking at Ozempic, but only in those people who did not lose weight on Ozempic who had arthritis symptoms, but their arthritis symptoms improved, even though they did not lose weight, which, as we know, is a good thing to do when you have hip or knee arthritis. So from my perspective, at times, it's not chatting to patients about that wear and tear. It's about talking, as Kay has said, about patients in a holistic manner, trying to work out or establish, because most of the patients I see don't or have not had an injury that has led to their arthritis development. There's something going on in the background. And as Kay has said, arthritis is a spectrum. Now, the number of people that I see who have got, what we refer to as that grade 4 or severe arthritis, and I'm sure we'll mention uh, that wording or messaging to patients is incredibly important. So I don't talk to patients about that bone on bone anymore, because that automatically sets the patient down an avenue that you might not actually be able to sort of bring them back from. And so, from my point of view, you've got to treat the patient in front of you. Don't treat the images that are on your screen, because everyone's on a spectrum and they will respond differently. And as I say, our concept of osteoarthritis being that degeneration of the joint surface, we just need to back the bus up a little bit now and go, well, there's probably actually more to it. And so there's some lovely biomechanical, biochemical, and pathology studies are coming out, but are also in the process of being done that are trying to look at that.
Yep. Yeah, I love that. And you got off to a sizzling start, and you got already a couple of topics there I want to dive a little bit into a little bit as we go on, particularly injectables and particularly Ozempic and other options there. But also to, the language that we use and we'll definitely get to those, because I think they're really important for, clinicians, no matter how old or young you are. I think we could probably get better with the languages we use. But yeah, that's really great coverage. I find it fascinating though, Kay and Joe in particular, like, knees particularly be on the OA, and that progression tends to be on the spectrum. Like you have that, early onset, injury, the patellar dislocation, the ACL injury, the meniscus damage done often in athletic sporting events. Whereas the hip kind of, unless they're probably AFL soccer player or, you know, a really high level changing of direction athlete, sometimes those hips can kind of just be part of who that person is and the way they're kind of shaped and formed, and they just tend to sort of grumble along in the background without that really significant trauma. I think that's also too like a really interesting discussion point there, because you know, like you can have these young ones already in their early teens and early 20s who are already on the spectrum, for both hip and knee OA, which is a, you know, it's often considered to be this older person's, you know, problem. But we're seeing it happen in a much younger population. Would I be fair in saying that now, Kay and Joe, with what we know?
Yeah, and I think there's two parts to this that feel like they're opposite. And I feel like, you know, some of the stuff Nigel's saying about we haven't quite got to the right point now. And that is, you know, we're seeing people who've, because we're looking for it, and, you know, with our researcher hat on, we're often doing imaging because we want to, if you want to try and prevent or slow down OA, you've got to be able to measure it somehow. Once you start looking for it, you find it. So we've got a study in FAI where we had 100, nearly 200 football players, and between 60 and 70% have signs of early osteoarthritis of the hip. But it didn't matter whether they were symptomatic or not. So they were all football players, they're all playing football, not at an elite level, but they were playing, you know, playing once a week and training once a week. So we're seeing in 18 to 40-year-olds, 70% of people have some imaging changes on their hip, but it didn't matter whether they were symptomatic, had any hip symptoms or not. And it wasn't related to any hip symptoms or not. So there's these two things. We're seeing these early changes if we look for them, and we don't know which of those are actually going to go on and have significant hip symptoms or symptoms elsewhere that's going to make them more likely to need something more aggressive treatment-wise down the track.
Yeah.
And these people weren't necessarily seeking treatment. They were still playing football. So we see that a lot of people have these signs, but the signs aren't necessarily related to any symptoms that they describe. And we see the same in the knee. I just gave the hip one as an example.
Yep.
So we do have this dichotomy where there's a lot more imaging findings that we thought, but we don't know how important they are. And we don't know which people are going to progress. That goes back to understanding the condition a little bit more.
Yeah. Do you think is that part of just that we're going to get better imaging now? Like if we go back 20 years ago where MRI wasn't that readily available, or is it, and X-ray was often just the first sort of radiographic thing we'd look at?
Yeah, the imaging is better, and we are talking about a research setting. Like I would not be advocating MRIing, you know, an 18 to 40-year-old, you know, or having the imaging findings change treatment at this stage, because we really don't know. And as Nigel says, there's other sort of elements within the sort of metabolic pathway that actually might be more important than some of the more mechanical things we've always thought about as well. So it's trying to work out who is worsening more quickly than others so that we can sort of target treatments more effectively.
Yep. And Joe, you said before we were looking at, you know, we kind of now picking some mild OA changes up in the hip and the knee a little bit earlier. We're understanding now that it can happen younger, and we want to try and prevent it from escalating into more significant problems later on in life. What things in particular is available out now for available for physiotherapists and patients to provide that high value care? We're talking exercise, and if so, what does that look like? Yeah, where does the role of manual therapy sort of sit? Our traditional kind of physio tools. What is kind of seen as best practice now to help these mild to moderate OA sufferers?
Yeah, so I think that's a good question. And if we talk specifically about the hip, we don't at present we don't have any information about what, if anything, we can do to prevent the onset of OA in these patients. And when I'm talking OA, I mean the symptoms, you know, the picture of OA, not just the changes that you see on imaging. So we don't know whether anything that we can do prevents it, but we would assume that being, you know, meeting the physical activity guidelines, being physically active from a cardiovascular point of view and a strength point of view is probably beneficial. But then also with what Nigel was saying, dealing with the whole patient and the whole body and the metabolic factors as well, and addressing central adiposity and all of those sorts of things is important. But once someone has symptoms, in terms of what do we know works, if we look at the classic OA, the mild to moderate OA, and we think about the GLAD program, which I'm involved with at La Trobe Uni, the treatment pyramid says that everyone with osteoarthritis, whether it's of the hip or knee, should be doing exercise. And that's a combination of physical activity alongside joint-specific exercise. They should be doing they should be educated about their osteoarthritis, about all the things that we're talking about. And then they should be losing weight if it's appropriate. But I think we can probably be a little bit more nuanced with that. As Nigel said, like, you can get the benefits of changing the metabolic state, even if weight loss isn't obtained. So everyone
It's a big
should be looking at exercise, education, and weight loss.